We live in an unprecedented age of blame. We truly have a different population of patients. Now let me ask here, is everyone neurosurgery? Anybody with OB, peds, some of the other specialties? What are they? OB, oh good. I never could do OB. They scream too much. OB and NICU, any psych? I love psych, you know, you never get them better. Okay. Family practice, good. All right, yeah, there's just a revolving door with psych. Utah, OB too. All right, so what I want to share with you today is some good news. Good news in Utah, good news all over the country. Nurse practitioners, physician assistants, advanced practice providers don't get sued as often as physicians in the data that we collect at our company. That's good news. Now, let me preface it by saying, many times you're going to consult out those difficult cases. You're not always doing the high technical skills surgery the physicians are doing. So keep that in mind. But overall, patients, we have doctors here. Patients are happier with you than the physicians. Now that's the data, that's not just me and my preference. That's the data. So what I've done here is I put together the claims study in not necessarily this order, but the allegations, and that's what you'll see on a lawsuit, what they're alleging went wrong with the care against an advanced practice provider. And I'll let you read those, I don't need to read them. But let me ask you this. The failure, error in diagnosis, the failure, delay, misdiagnosis. What specialty at the doctor's company do you think, after our study of error, delay in diagnosis, was the #1 specialty that caused a claim? Remember, a claim has to have damages. ER, good selection, nope. But they were in the top 10. OB, nope, in the top 10. Nope, pediatrics. Okay, and I tell you what diagnosis it was, you'll go, yeah, talk about damages. It is not autistic. What is it? Very close, meningitis. Okay, I had an office call me from back east. Remember St. Elsewhere? And she said, we've missed 4 of these. It was a big pediatric group. We've missed 4 of these a year, this year alone. We've got to do some work on recognizing it. All right, so you can see there what those basic top allegations are. All right, indemnity paid out. This is the money that the insurance pays out on your behalf for these claims. You can see there's not much difference between nurse practitioners and PAs. And I don't really think the number's important in comparison of the 2 disciplines. I think what's important is to look at the amounts. Ta-da. So we look at the contributing factors that we have identified with the claims. Documentation. I had a call from a physician's assistant, about a week and a half ago. And this is a really, really difficult call for me to take. As many of them are. Some of them are stupid, like our doctors in the back room making guns. What do we do? Those are the easy calls. I'm not making this stuff up. I was in Seattle to a pediatric group and they said, Dad wants a letter from the physician, the pediatrician. I'm glad we don't have pediatricians here. That said breast milk is the preferred formula for the 9-month-old child because he's going to take it to divorce court, convince the judge that his new girlfriend, who also has a newborn child, can breastfeed on the weekends. Yeah, crazy stuff. Crazy stuff. So this call came in, and I could sense some anger with this PA. And he said, I've got a problem. I had a 26-year-old come into the urgent care that I work at in a very, very small, remote area of another state. He said, 26-year-old came in, shortness of breath. We put the pulse oximeter on him, on his finger. It was cold. We didn't get much of a reading. So I put it on his toe, got about 76. I said, you documented that? Oh yeah, they documented that. Blood pressure? We could never get a blood pressure. We didn't waste our time. And I said, then what happened? He said, well, I offered a couple of treatments to him. The nebulizer, those things that y'all do there. And he refused them. I said, you document him? Yeah, I sort of documented him. Okay, what else? Well, I really wanted him to go to the hospital, but I didn't bother telling him. Because let me tell you, he's just trailer trash. He was trailer trash from the time he walked into the door. I knew he wasn't going to go to the hospital if I advised it, so I didn't bother wasting my time. The next day, this patient died. That was a hard call to take. Do you think this provider was distracted by things that didn't matter? Yeah. I didn't know what I could do to help him. You know, my job as a risk manager is different than Katie's. She gets to find out all the details and ask the whys. I just try to help him through this process. And he was angry. And I said, let me tell you what, across the board, it doesn't matter what the socioeconomic class of your patient is. It does not matter whether they're more likely or less likely to sue you. Okay, documentation. We're going to get more into that as we talk about non-compliant patients. Consent. First thing I've ever done when I look at a medical record, what are the allegations? Show me the consent. Show me the consent. Is it a risk of the procedure? And then I'm going to go in and see if there was a discussion between the provider and the patient to specific risks that maybe the patient was susceptible to or worried about. If a patient's diabetic, there's certainly going to be more concerns with surgery as not. Laboratory diagnostic test and consult tracking. The doctor's company, we always do these sorts of studies. And one study we did is we looked at medical offices and say, okay, what is the biggest risk of a medical office in getting sued? The failure to track their labs, tests, and referrals. And I know what y'all are thinking, well, isn't that the patient's responsibility? I ordered it. You know, if they don't want to get it, not my problem. Well, here's what's happening more often than that. The patient's getting the results. They're just getting lost in the electronic record. They're not being reconciled. Had an ear, nose, and throat physician who'd got a complaint from Blue Cross Blue Shield. Something you do not want to get is a complaint from a third-party reimbursement company, Medicare, Medicaid, Blue Cross, United Healthcare. We're seeing more of them. Why? Because they know that delay in healthcare, that delay in diagnosis, breast cancer, those sorts of things are going to cost them money. So this particular patient went into the ear, nose, and throat doctor and got an MRI. He kept calling for the results. The office never got him the results. 3 weeks later, he got fed up with it, made a complaint to the medical board, as well as Blue Cross Blue Shield. Of course, the medical board came in. They call me on the phone, as well as we provide nice counsel for them. Remember that young, aggressive, defensive attorney for them. And we had to also help him answer the complaint to Blue Cross Blue Shield. The office manager was really frustrated. She said, Michelle, will you come into the office and tell my staff how much of a problem it is to do the paperwork, to contact you. You've got to get an attorney, and everything that's involved when we get a complaint from the Board of Medicine or Blue Cross Blue Shield. I said, I'm not going to come in and tell your staff that. I'm going to come in and tell your staff what it's like to sit down with a patient when there's been an injury or harm because of something the office failed to do. That's where the rubber meets the road. So went through the program, and I offered them an idea of how to do a manual reconciliation with the test that's ordered. First front row person raises their hand. First thing she said to me, that ain't gonna work. Somebody else said, we're not gonna do that. The physician was sitting there. He jumped up, never seen him so excited, jumped up, and he said, oh yes, we are. We are going to do this. Leadership is critical. It's the only trickle down for those that love politics. The only trickle down that I've ever seen is when leadership takes charge and demands excellence of care. So a week later, I emailed her. I said, Celeste, how's that staff of yours working? How's that lab tracking? And she said, you know what? It's working. Between the doctor getting up and saying, we will do this, A couple of the staff folks said, why don't we just print an extra sticker and put it on that sheet of paper so when we can do the reconciliation at the end of the week, it just is really quick because we've got all the patient information on the sticker, we put it in the book and we cross-check and we get little Disneyland stickers if everybody's done the job for the week. Good, good. Another component is patient education. If it is a critical test, you need to make sure that test is ordered or scheduled, that referral, on that very day the patient's there at your office. You get me going on that, I could be another hour. Let's see, communication. All of our claims have a communication issue. Wow, something fell through the cracks. Communication's got to be repetitive, it's got to be redundant, repetitive, almost to the point of disrespect, because you keep reminding, yeah, I see some of the heads shaking, oh yeah. Referral and transfer of care. I'm not going to say too much here. Again, documentation is really critical. Document that patient understands. Because when it all comes out in the end, the jury loves their physicians and they love their providers. They respect what you do in the community. They're going to always defer to your documentation, as that is the way it was. Okay, we're going to have that young aggressive attorney, Kate, come up and talk to you about what's going on in Colorado. And she prefers the podium because she's been in court more recently than I have.
Hi, I'm Kate Bailey. I work at Mesner Reeves. I've been there for the past 5 years. And my specialty is defending healthcare providers and entities against malpractice claims, and then providing ongoing risk management advice, usually to prevent this from happening again in the future. Michelle asked me to talk a little bit about what we see as kind of the big pitfalls with healthcare providers, and specifically with non-physician providers, where we see the biggest concerns once a case actually gets to litigation. But before that, I do want to go through the elements of a malpractice claim, and I think I can do that. So, in order for a patient to file and win a lawsuit, they have to establish that the non-physician healthcare provider had a duty to the patients, and you all have a duty to competently treat your patients and to do what a reasonable healthcare provider in your situation would do. And that's established usually by another expert healthcare provider. Once they've established that there's a duty and that you have a duty to that patient, they have to show that that duty was breached. And obviously breaching the duty means that there was some act of negligence, there was some way that you did not do what you should have done in that situation. Michelle did want me to talk about causation. Just because a mistake was made, we all make mistakes in our professions, doesn't mean that you actually caused the harm. And so there are situations where we're defending a lawsuit where there hasn't been adequate documentation, where there maybe was not the best conduct, there wasn't the best treatment. And so then we have to focus on, okay, but did that actually cause the harm to this patient? And we do sometimes have to defend our physicians and our healthcare providers on that piece. That's not the preferred method, but you still are the only profession that is not allowed to make mistakes. Damages, I think, are pretty self-explanatory. In Colorado, there is a cap on non-economic damages, and what that means is that a person can only recover for pain and suffering up to $300,000, but they can recover on any medical expenses that were tied to the event, any anticipated future medical expenses, and any expenses that are related to fixing the problem. So as far as problems that we see, things that we are seeing being raised to the nursing board, being raised to the medical board in Colorado, being issues when we're litigating these cases, it's becoming more important that our healthcare providers are careful about how and when they're accessing a patient's electronic medical record, especially if there has been a potential adverse event. The plaintiff's attorneys are allowed to go and get the audit trail for a patient's electronic medical record. And what that means is that they can see who's accessed that patient's record and when. And so if there has been a potentially adverse event, and then the next day or a few hours later, a healthcare provider is then going in, looking at that record, altering that record, that there can be an implication there that there was a concern. And so if there is a potential adverse event, one of the most important things that you can do is, rather than taking it upon yourself to do an investigation, taking it upon yourself to have a discussion with another healthcare provider about it, is to go to your risk manager and make sure that it's something that you report to them, have a conversation with them, let them handle it. Those conversations too that you have amongst yourself after there has been a potentially adverse event are also discoverable, meaning that they can ask about that at trial, they can ask about that during litigation, and you have to be honest and truthful about that. And so you want to try to not have any discussions or do anything that could look like there were concerns, and just take it straight to your risk manager. And this was something we were talking about earlier. I can't remember with whom I was speaking, but distractions in the operating room. A lot of you are using personal devices to work, to contact other people. But because of that, because your personal device can be used in the workplace setting, once a case ends up in litigation, if it does, then they can get access to your personal mobile device and see what you were doing during the relevant time frame. So if you were in the operating room and you were on your cell phone, they can get the records from that cell phone and see whether you were browsing the internet, whether you were texting your friends while you should have been taking care of this patient. So that's something to keep in mind. Calling patients on lab results and documenting it. And this is something that Michele touched on, but document, document, document. You will be so grateful that you documented everything and that you were more thorough than not when 3 years from now, if you're involved in litigation, you're asked to remember a patient visit from three years prior. And the more detail that you have contained in there, you're going to better be able to refer to that documentation rather than your own memory of the events. And with the amount of patients that you see and treat, it's so critical that you document as much as possible so that if and when the time comes, you have something to refer to, and that you can be sure that you covered all of your bases at that time. Communication. Michele touched on communication. Most hospitals, clinics do have a policy. There are actually national standards that have been put out by the U.S. Department of Health and Human Services that for non-English speakers or people who are not competent English speakers, that they need to have access to either bilingual staff or an interpreter. And that has become an issue over and over again in litigation, that even if there is documentation that a patient was given the information and understands it, there might be a question as to whether they really did understand it, because there is that language barrier there. And so the national standards highly recommend that they be provided access to interpreters so that there's no question that they understood the information that was documented. I think that's all I've got for now, but we'll have a time to ask questions, and I'll let Michele move on to some questions and answers.
This is the part we talk about some of the non-compliant patients. It's what you came for, right? I'm going to have some coffee to help you out. This is a particular call that came in about George, something I think you would see in your practice, except maybe if you're OB, but it could certainly be Georgia. George is a 68-year-old patient who's increasingly non-compliant, belligerent, refuses to pay his copay. In fact, he's gotten so bad he's physically threatening to the staff and disruptive to the other patients in the waiting room. The office manager has asked that George be terminated from the practice. Have you all met George? Okay, all right. And just for the sake of argument here, look around. Does any of you see a difficult patient? How many of you are difficult patients yourself? Oh, I am. If an MA doesn't introduce herself to me or himself to me, I'm like, excuse me? Okay, so yes, this is George. Healthcare is hard for the patients. It's a hard system, and it's even harder for providers. So the office manager comes to you and wants to discharge George. What do you say for a cup of coffee? What are the things you want to look at? Yes?
What else is going on?
What else is going on? Why is George acting this way? Excellent. Starbucks. Psych evaluation. Excellent. For some of you work in neuro. That's huge. That's huge. Anybody else? Who do you like today and who do you not like today? Okay. Exactly. Did you have a comment?
We asked what our responsibility is to the patient. Have we done everything we could?
Have we done everything we could? I think that's good for a coffee card. All right. What we want to do is we want to look at, is George in an acute phase or critical phase of care? Okay, will my termination of George from this practice cause him problems? Can he go 30 days, which is the legal requirement? In Colorado, by the way, if you're a specialist, it's 15 days. But if you call me, I'm going to say try and squeeze out another 30, because we don't want a letter from the medical board. Give him the benefit of the doubt. And will 30 days impact his outcome of his care? So that's something you want to talk about. Okay, does George's behavior justify a referral? Excellent point. How about third-party contracts? Ooh, that might specifically, depending on where you practice and your specialty, require you to read that information. Can you terminate him? Boom. And is there a medical reason for his behavior? Can you do everything for George as possible? So let's see. Part of your handouts, and you don't have to pull them up in front of you, is some handouts on terminating non-compliant patients, as well as some sample letters that you can take to your leadership of your organization and say, hey, I got a few patients for these. And also an internal document that I created that asks all the questions that you need to ask yourself. This is not something for the medical record. I don't want Katie to ever come across it when she gets a copy of the medical records. It's internal document. Questions like input from the insurance or the billing office. That's huge. Ask the physician or the provider, in your case you, is there something we don't know about George that's going on? Another one is what's his outstanding balance? That can play an impact. Does the chart have sufficient information to terminate George? So here, what else could be considered? The family resources, you guys were right. I gotta pass out more coffee cards. Anything else that you can do? Let's say you can't get rid of George. Okay, because I know you got patients you can't get rid of. A behavior contract. One-on-one. And check and see if he can take responsibility for his behavior. You bet. In that case, the behavior contract is excellent. Yes. And I have worked with staff and offices for that, behavioral contracts. Had a patient that was receiving chemotherapy for breast cancer. And the office didn't know what to do with her. She did everything right except misbehave in the waiting room and would talk badly about the providers. I mean, it's the worst than social website. This is the waiting room. And so they pulled her in, identified the behavior, made her aware of this with her family, signed a behavioral contract, and she was able to continue to get the care. Okay, which are the following steps? How do you terminate, and no office managers, Leslie, can answer this one, because you know how to do this one well. What are the appropriate steps? It's decided we're gonna let George go. Yes? Letters. What does the letter say? One of those sample letters. I already gave you the risk for termination. Do you have to give the patient a reason? No. Sometimes it's not wise to give them a reason. You know, you want to beat up the staff. Yeah.
The letter has to tell who you're going to refer to, or
Make recommendations for possible referrals. Okay. Oh, the hands are flying. Adequate time frame, 30 days. Again, Colorado has a unique 15-day clause. What else do you want to make sure George has in his medicine cabinet before you turn him loose? I got to get somebody who doesn't have all my coffee cards. Have you had a coffee card? Okay. She's got my PowerPoints. Of course she knows the answers. Okay, medicines. You bet. Make sure he has enough medicine. Let's see if we missed any. Provide the notice in writing. Now I always say certified, send it regular and certified. Who picks up certified mail? Not me. I'm a lawyer, I'm too paranoid. Refer, I like that comment that came over here. Absolutely make some referrals. Make them general referrals. And I give advance notice, we talked about that. And 30-day supply. Okay. 33-year-old high-risk pregnant patient is scheduled for a C-section. Yes?
Back on providing adequate medication, does that mean they actually have to have the pills in their homes, or that there is adequate scripts at their pharmacy for them to?
That, depending on how you calculate it in the medical record, that they have enough of a 30-day supply, because the laws determine the 30 days sufficient time to find a new provider.
But if they are not compliant with picking up their meds at the drugstore.
Not compliant with their meds from the district. I'd say they've got 2 months worth. If they've got 60 days waiting at the pharmacy, you've more than met that. Again, you want to document that you've calculated that. Okay, for those that like OB, boom. You got a mother, 32-year-old high-risk pregnancy, due for a C-section scheduled 4 weeks from now, and she's not bringing in this copay for $500. Now, this was an actual call, and it was the office manager that called me and said, the staff and I want to terminate her. We're tired of her showing up with no money. I know, can we terminate her? No. I mean, really? No, absolutely. You've got a copy card. He knows all the answers. He's going to start giving them away. Of course, you've got to see her. And then what do? Do you find a buddy to take her on? There's no buddy that's going to take her on. No. What do? She owes you money. Well, she's been already on a payment plan. 0 up front. Get the baby here. Is that what you're saying? Get that healthy baby here. And then what? Send her to collections. She's right. Work with her. Work with her. Federal aid or something. TRICARE, work with her. They did all those before. You still earned your coffee card. They couldn't see that. Hey, we'll deal with this afterwards. Let's put the patient here before the billing. Can you get terminate? Rid sounds like a pest control. Can you terminate a patient for non-payment? Absolutely, yes. If they're not in the critical phase of treatment, they have a 30-day supply, you notify them in writing, it's not going to adversely affect the outcome. Okay, I have to share this case with you, okay? 3 more coffee cards. 4. This came in last week. It's funny how you get it assigned a program and then all of a sudden the floodgates come open. This is a 69-year-old with an ulcer on his small toe, refuses the wound clinic. He was very gamey with the provider. She finished a round of antibiotics. She felt like he's going to lose this little toe. He won't do anything I say. By the way, he was a retired physician. Okay, so did he know everything? Maybe that's why I'm the difficult patient that I am. Okay, what do? You reach out to a trusted colleague and say, what do I do? What do you want that trusted colleague as you? What would you say? Sit down with him. He's just gamey. He's manipulative. You don't have those patients, do you? Yeah. He's in denial. He's a physician. He knows it. Okay? He won't go to the wound care. Memorialize the recommendations in writing. Documentation. And you're going to tell him what in the letter? You don't get this treated, it's going to cause your death. Don't be afraid to use that word death, because they need to know. Okay? Because he may be worthless to himself, but I'm going to tell you what, he dies, he's priceless to his family. Yeah, and then Katie's got a mess to deal with. Kate. Okay, what else? Send him to another colleague, get another opinion. What was that?
Send him home health, evaluate what is going on at home.
Yes, send him to home health. Have you already got a copy card? Okay, raise your hand. I heard the right answer here in the back. Let's see, there was somebody else I wanted to give one to, because she was nice to me and sat by me in lunch. She did. When all of you guys went your own way, she sat by me. Sally, thank you. You got to memorialize everything. Can she terminate him? Oh, she wanted to terminate this patient. She wanted me to, give her permission. I'm not going to do that. Absolutely not. She cannot terminate this patient. Okay, you got to navigate through that. Send him letters. You bet, Billy, really strong. And continue. Document. I explained to her what I'm going to explain to you. Most physicians, providers, when they get a lawsuit, it's from patients they had no idea. They never saw it coming. I said, you are lucky, provider, because you saw this one coming. And you get to document, and you get to make that record look so good. And this is your opportunity to give great care. And she goes, wow, I didn't think of it that way. Oh yeah, this is a good thing for you. All right. Maybe notify the family. Does HIPAA allow you to notify the family? Yes. Yes. No. No, there is a great exception that when it is in the best interest of the patient, you notify the family and say, look, your daddy isn't cooperative. This is very serious. So there is that great exception under HIPAA. Do not let HIPAA prevent you from giving the best possible care in a patient that may not understand, even though he's a physician. Okay, retired. Notify primary care providers, enlist the troops. Okay, so we'll just start thinking of all the things that you can do. I don't think he goes to the level of adult protective services quite yet, but he's not making good decisions. He still has the capacity to make decisions. All right, one of your patients, this is the last one, gets excited with those cards. One of your patients is arrested. It makes the newspaper for animal cruelty, and I won't tell you what it is. It came out of Florida. But the office called me and said, do we have to still keep seeing this patient? It was a dentist. Yes. How many say no? Raise their hand. How to say no? You're right. I see somebody back here who doesn't have a coffee card. You do not have to see this patient. Okay? Fortunately, in a dentist situation, there was not a critical phase of treatment, and they could let him go. You think that was an easy call for me? Yeah, as long as you're not terminating a patient based on a discrimination protected class. Okay? Then he said to me, do I have to see his wife? And I said, oh, why do you make it hard? Because how do you morally, not legally, because you don't have to see anybody if you don't want, as long as you're not terminating them for one of the protected classes. How do you morally not see his wife? And I said, I'm going to leave that up to you, I said, because I can't tell you yes or no. But you don't have to see this man. And it was a very, very offensive. I think any cruelty animal can be offensive, regardless how small or how large. It's offensive. All right, that's it.